If I give an anticoagulant and a aspirin to a younger patient, they're going to be less likely to experience bleeding than if I'm giving warfarin and an aspirin to an older patient, because the elderly patients are more susceptible to adverse drug reactions. So let's talk a little bit about pharmacokinetic changes in the elderly. So like I said, pharmacology is broken down into two key terms, right? So we have pharmacokinetics and pharmacodynamics. So when we're talking about pharmacokinetics, it describes how the body processes a drug, or what the body does to the drug. That's kind of very simple terms what pharmacokinetics are. So then within pharmacokinetics, there's these four key terms: absorption, distribution, metabolism, and excretion. So this might be all well and good, but think about this application to your patients, right? So if you have a patient coming to therapy, for example, you want to know when a medication is going to start working, right? So if I'm giving a medication, I want to know when is it going to start working. Not only that, I want to know when am I going to see its peak effect, right? Because if you're using like hardware therapy or something like that, like it would be ideal to time it around when the medication is at its peak effect. Or when they're experiencing side effects is another time when it's at its peak effect, right? So if they're getting particularly dizzy, that's kind of usually, thinking about the peak effect of the medication. And also we want to know how long it's going to stick around, right? So if our therapy lasts 2 hours, is the drug going to last the whole time, or is it going to be gone halfway through and do I need medication again? So that's kind of trying to make these terms relatable to, why they're important. So absorption is how fast the medication gets into the bloodstream. So when we're talking about absorption, we're talking about specifically for oral medications, right? Because if we're talking about absorption in IV medication, it's already absorbed, right? Because we're giving it right into the bloodstream. So we're talking about oral medications when we're asking or thinking about absorption. So the key thing in absorption is your GI tract, which changes with age. So as you're getting older, there's reduced GI motility and GI blood flow. Also, there's pH changes in elderly patients. So an elderly patient will have less acidity in their stomach, right? Which is partially due to physiology, but it's also partially due to medication. If a patient's taking an antacid, like calcium or Tums or something like that, or if they're taking a proton pump inhibitor, Prilosec, or if they're taking Zantac or Pepsid, these are all medications that are changing the acidity in the stomach, which then changes the absorption, okay? In terms of reduced GI motility, if, I think that's all I want to say about that. Okay, so absorption is the least affected in terms of all the parameters with aging. So we're going to talk about a bunch of other parameters. Absorption is kind of the least significant in terms of all of them. But elderly patients also have other problems that kind of confound absorption. So swallowing difficulties and poor nutrition and feeding tubes. These are all things that also affect absorption for these patients. All right, so distribution is the next term when we're talking about pharmacokinetics. So distribution is where the drug goes after it enters the bloodstream and how it gets to the site of action. So a drug basically, unless it gets to the site of action, it's not doing anything in your body, right? So that's why we care about distribution. And when we think about distribution, the way we describe it is the volume of distribution, which is the amount of drug in the body that's relative to the concentration of drug in the blood. So when you're thinking about a drug, like you're giving it, it's going from the GI and then it's going into the blood, right? And then, don't touch that. And then, from the blood, it's then going to the various water and the various organs. So that's kind of when it's distributing into the water. It's also going to specific organs like fat or tissue, and that's specific organs. And then it's also going to general organs. So we have to think about fat, water, muscle. So these are all things that are affecting distribution in the body. Also, the properties of the drug change the way the drug is distributed in the body. So if a drug is protein bound, that's going to distribute one way. If it has, if it's different pHs are going to work differently. And then also if it's a water or a lipid soluble drug, those also changes the drug distribution. And it's important to know and think about, this is how we get to the drug of concentration that's effective in these patients. So that's kind of why distribution matters, right? You need to get the drug, you need to get it to the receptor, so you need to know how much drug you get to the receptor. So in elderly patients, we see some changes. So we see changes in their muscle mass. Is the muscle mass in elderly patients going up or going down? Going down, right? So if a drug is distributed in muscle, it's going to be less distributed in elderly patients into their muscle, right? So if it's not going into their muscle, where is it going to stay? It's going to stay in their blood, right? And it's going to stay in their blood, and it's going to have more effect and more side effects, okay? What about fat? So as people get older, does their body fat go up or go down? Up? Yeah, relative. So their body fat's going up. So again, certain drugs are more lipophilic drugs are going to be distributed more into the body fat, and again, they're going to stay less in the bloodstream. An example of a drug that's going to go more into the fat is Valium. So Valium is a highly lipophilic drug, which means it loves fat, right? So if I give an elderly patient Valium, it's going to go into their body fat, and it's not going to stay in their blood, which kind of interestingly means that the Valium is going to have less of an effect in the elderly patient. There's other reasons that benzodiazepines have more of an effect in the elderly patient, which we'll talk about in a little bit, but Valium's a little bit unpredictable because it likes body fat. Another change in elderly is they produce albumin. So albumin is the protein that we have floating around in our blood, right? And albumin is important when we think about drugs because albumin binds to a lot of drugs. So that's why it's important. So if you have less albumin floating around in your body that likes to bind drugs, what's going to happen to the drugs? What was that?
They won't be absorbed.
They won't be absorbed. So that's something, but they're already absorbed because they're already in the bloodstream, right? So we want to think about if a drug is bound to albumin, it's not acting, right? Because it's kind of bound and not doing anything. So it's not going to be bound, it's going to be unbound, and it's going to be floating around and free to do what it wants, right? So we're going to see more of an effect, and we're going to see more side effects in elderly patients. So a good example of a drug that loves albumin is phenytoin. So phenytoin is a med that we use for seizures. In elderly patients, they experience a lot more side effects associated with phenytoin because they don't have the albumin, and so it's floating around with the blood, happy to do whatever it wants. So distribution is important because it changes the dose that's necessary to produce the desired effect and avoid side effects. And distribution is kind of hard to predict. Like I just told you, Valium, you might need more of a drug. Phenytoin, you might need less. A lot of drugs, you can't monitor levels, right? So what do? And really, the only thing you can do is you start with a low dose and you go slow and you increase your dose gradually until you get the effect. So that's distribution. So the next parameter that we're going to talk about is metabolism. So metabolism basically means we're converting chemicals from one form to another, right? And the primary organ that we have in our body that likes to metabolize drugs is our liver, okay? So as you're elderly, your liver changes from a couple reasons. First of all, the blood flow is reduced in your liver, right? So getting the drug to where it's going to be metabolized is slower, right? Because that's what kind of moves the drug to our body, through our body is our blood flow. So it's going to be slower getting to the liver. Also, the liver mass is smaller in elderly patients, and the intrinsic metabolic activity is also reduced. So we're going to talk a little bit about the metabolic activity in our liver. So we metabolize drugs in two ways in the liver. The first is oxidation, and so the oxidation uses cytochrome P450s or CYP450s. Have you guys heard about those before? Ever? No? Okay. So CYP450s, those are enzymes, and they're enzymes that are important because they take a drug that's not active and they make it active. So that's kind of why they're important. So a lot of times we're swallowing something, it doesn't do anything, then we get into the liver, these CYP450s make it active and make it do its job. So that's why the CYP450s are important. Another type of metabolism we have in the liver is conjugations, which actually do the opposite thing. They're taking drugs in your body that are active and they're making them inactive. So they're making them usually larger and they're making them inactive. So these are the two things that are going on in our liver. Like I said, your blood flow is reduced, you have less enzymes. You know, we have more drugs working on these enzymes. So some drugs make these CYP450s work faster, and some drugs make these CYP450s work slower. So we have a lot of drug interactions that are happening at this part, particularly in older patients. The net result is it's kind of hard to predict. So, I can't say, oh, you look like you're a good liver patient, like here, take this much drug. It's kind of hard to predict with these patients. So again, this is something that, unless they have really poor liver function, we don't know what kind of drug to give them and how much to give them. So they say usually it's a good rule of thumb to give lower doses to patients if the drug's metabolized hepatically, and then just increase the dose to an effect. Oh, and you guys can ask me questions, like if you want to know something, then just raise your hand or shout out, and that's fun for me. Okay, so the next parameter that we're talking about is excretion. So excretion is elimination of drugs from the body, and the organ that we use to excrete the drug out of the body are the kidneys. What's nice about this parameter that we have is we actually know more about this than on any other pharmacokinetic parameter. So I can take a patient and you can get their creatinine clearance, which is how good their body is at excreting drug out of their body. And then luckily the FDA has given us information about, if a patient's creatinine clearance is this like 30 mils per minute, you give them this dose of drug. If the patient's creatinine clearance is 50, you give them this dose of drug. So this is the one parameter that we really have more information about when we're making judgments about a patient or making decisions about a patient. Another way we can get their creatinine clearance, you can collect a patient's serum creatinine for 24 hours, which is probably not a popular choice. Or we can use their serum creatinine once, right, in a lab test, and then we can calculate their creatinine clearance using these two different equations. So it's nice that there's that information there. We care about creatinine clearance because that's the half-life of a drug, right? How fast a drug is getting out of the system is dependent on their clearance from the body. So that's why we care about a patient's excretion. Thinking about if you're looking at a patient and you're like, why is this drug still sticking around? That's one of the good places to look, is look at their excretion, and you can calculate their half-life usually. So it's kind of a good piece of information that we have. So the net result of all of that is there's a lot of changes in pharmacokinetics for a patient, right? And a lot of them, I'm telling you, are difficult to predict for these patients too. The absorption is the least minimal. The excretion is the most predictable. So kind of just having that knowledge.
So can I ask a question then?
Yeah.
I had a patient the other day that was telling me she has osteoporosis, and there's a new to me, osteoporosis medication that it's a bisphosphonate, I think, and you only have to take it once a month, whereas with glucosamine, I think you used to have to take it every day. Is that because of the things that you just said? Is it because of that allows that to happen?
So partially it is. Bisphosphonates are kind of an interesting class of drug. So Fosamax you can either take daily or weekly, and then like Boniva is another drug, you can take that once a month. Actually, all bisphosphonates have a longer half-life in general in all patients. So in their blood they have a longer half-life. What's also interesting about bisphosphonates, is they distribute into your bone, and that's where they work, right? And they have a very long half-life in your bone. I think Boniva is a good example. It might be like 4 to 6 years is the half-life of Boniva in your bone. So, we look at drugs and they usually have a half-life of 8 hours, but this is years that this drug is sticking around in the bone. So it's distributed into the bone and it sticks around for a really long time.
So is it still calcium with vitamin D that's supposed to be what people are advised to take if they're trying to absorb calcium?
Yeah, so yeah. Now, I think last year something just came out about vitamin D and elderly, and that's kind of become a little more controversial. So yeah, but yes, you're right. Like if you're giving someone a bisphosphonate, you should be giving them probably calcium and vitamin D with it, because you're trying to build bone matrix. You need something to build the bone matrix with, so that's why you're giving the calcium and vitamin D. But vitamin D is controversial. Okay, so another change is pharmacodynamics. So we talked about pharmacokinetics, what the body does to the drug, right? Pharmacodynamics is how a drug affects the body, or what, did Did I say that right? What the body does to the drug. And this is what the drug does to the body. So that's kind of a good way to think about it. So as you're aging, there's more or less sensitivity to a drug. So drugs are exerting their effect at sites of action, right? And these action sites are either more or less sensitive to medications. And that's primarily because of aging. So we can look at, it's difficult to predict some of the pharmacodynamic changes in the elderly. Again, it's kind of something like you don't really know what's going to happen, so that's why they say start at low doses and increase your dose. That's kind of the mantra for today. But just kind of think about some pharmacodynamic issues. So orthostatic hypotension is one that we see commonly in antihypertensive, and it's usually at starting doses, right? So we see a patient, they have more sensitivity to these antihypertensive. Why is orthostatic hypotension matter in elderly? Like, why do we not see it as much in younger people? Because we're starting them both on amlodipine, right? It's a good drug, causes a lot of hypotension. So why do we see it in elder patients and not younger patients?
They're not as active.
The receptors or the patients? Maybe. So that could be one of the reasons. Also, so I said the receptors are more sensitive, so that's one of the things. Also, the body's response isn't as effective. So your body isn't as good as blunting the response. So when they develop orthostatic hypotension, your normally body has like ability to kind of combat that. So they'll increase some fluids and they'll do that, and your body's able to compensate for the orthostatic hypotension. Elderly people aren't as effective at doing that, and so that's why you see a more profound effect in the elderly. Propranolol is kind of a weird drug, so it's a beta blocker. They use that a lot for migraines, right? You see a lot of the headache patients on propranolol, maybe? Propranolol, nadolol. It's interesting because beta receptors are less sensitive. So we're saying like, you need more drug, you need more drug. So this is kind of a weird one where, the beta receptors are less sensitive. So you're going to require more doses of beta blocker to get your effect. So it's kind of the opposite of all the other examples we've been talking about. Anticoagulants, you see greater sensitivity to drug action. And so again, it's important to initiate with lower doses. And then diuretics, again, it's greater sensitivity to drug action. So if you're starting Lasix, for example, in a patient, they're more likely to experience dehydration when they're taking Lasix, or they're more likely to experience electrolyte disturbances taking Lasix. So we see a lot of more profound effects in the elderly. Next, I just wanted to talk briefly about adverse drug reactions. So the risk for any person taking a medication to develop an ADR, adverse drug reaction, is 20%, but it's pretty high, right? Like taking aspirin, developing an adverse drug reaction. So it's higher in elderly patients. About 10.7% of patients require hospitalization, of elderly patients experiencing an ADR require hospitalization, and that's 5% with the general population. So we're seeing that it's more profound, right, in elderly patients. Also, the number of medications used in the elderly is higher, and as you increase the number of medications that you're taking, you increase your likelihood to experience an adverse drug reaction. So if you're taking 1 to 2 medications, which we just said not very many elderly patients are taking 1 to 2 medications, then your risk of experiencing an adverse drug reaction is around 20%. As you get to 6 to 7 medications, the risk for experiencing adverse drug reaction is 100%. So it's kind of like a double-edged sword here, right? So let's talk a little bit about some common medications and some of the adverse drug reactions that we see. So anticholinergic effects. I think this is probably one of the most dangerous adverse drug reactions that we see in elderly patients. So we're going to talk a little bit later about falls, and really it's anticholinergic effects and probably in combination with mental status changes. If we're looking at a drug causing a fall, that's probably one of the places that we can contribute to. So how do anticholinergic effects manifest themselves? Dry mouth, blurred vision, hypotension, worsening glaucoma. So if you have glaucoma, your intraocular pressure increases when you have anticholinergic effects. Also, sedation, confusion, and disorientation, and impaired gait and balance. So the kind of drugs that usually cause that, first generation antihistamines, so Benadryl. A lot of times people are on Benadryl for sleep, like you see elderly patients on Benadryl for sleep. And this is kind of what, you need to be concerned about is anticholinergic effects in these patients. Also antipsychotics, antidepressants, GI motility agents, and that's particularly Reglan is kind of the drug I'm talking about. Also certain analgesics like Ultram and over-the-counter cough and cold preparations. So a lot of those drugs are causing the anticholinergic effects. And what's kind of terrible about also this side effect is it's insidious. So you don't know, like a person can be, it's not like give them the Benadryl, anticholinergic effects. Like this is potentially they can be taking this medication for weeks or years, and then they'll start experiencing anticholinergic effects. So it's kind of difficult to associate, right? Mental status changes is another side effect. Confusion, excessive sedation, delirium, trouble concentrating, memory loss, impaired gait and balance, and deficits in judgments. So basically on any of these anticholinergic effects, they're also causing potentially mental status changing, also muscle relaxants, and probably drugs that affect electrolytes. So those are like your diuretics, those are the kind of things that you'll see changes in electrolytes. It's causing confusion for different reasons, but it's still causing confusion and mental status changes. And all these effects are also additive. So if you have someone on Benadryl, and then you put them on Zoloft, and then you put them on Tramadol. So these are all additive kind of effects for the patients, okay? Orthostatic hypotension, we'll talk a little bit about this later, but you see a sudden decrease in blood pressure, dizziness, falling down, and a lot of blood pressure medications, this is kind of a common one, but also narcotics and antidepressants. And then GI disturbances, constipation, diarrhea. So again, diuretics, anticholinergics, antibiotics, calcium channel blockers, that's a common one that causes constipation in elderly patients, and narcotics, we didn't mention narcotics. And a big thing with this is if a patient's experiencing severe constipation or diarrhea, they're going to be less likely to be compliant and less likely to get the full benefit from their medicine, right? And then cardiac changes. So a lot of medications that patients are taking can cause cardiac disturbances or cardiac changes. So we look at QTC when we're looking at an EKG. That's one of the things on the EKG. A lot of anticholinergics, antipsychotics, they can cause changes and they prolong the QTC. If your QTC is prolonged to a certain extent, then you're more likely to have arrhythmia. So that's kind of something to think about in elderly patients. And just thinking about ciprofloxacin, that's a common antidepressant that can cause QTC prolongation, and Zofran, that's a common anti-nausea that can cause QTC prolongation. So these two drugs together can have more likelihood to cause arrhythmias. So thinking about elderly patients, we said they're living old, they're living longer, they're older, they're taking a lot of medications. They're taking a lot of medications because they have other diseases too, right? So a lot of medications that we give that we're saying can cause side effects can also make certain diseases worse. So some examples of that is if a patient has diabetes and you're giving them steroids, then you have increase in drug-induced hyperglycemia. Also, antipsychotics, especially long-term, you can have metabolic abnormalities for long-term, especially some of the newer antipsychotics like Abilify is kind of an example. Osteoporosis, so long-term steroid use can increase your fracture risk. Someone had asked earlier, is that giving that for a week? Like if you're giving prednisone for a week, are you increase fracture risk? And usually they say around 3 months is kind of where you see that difference in fracture risk. Constipation with anticholinergics, antihistamines, narcotics, those drugs also the GI tract. So if a patient has underlying constipation and you're giving them those medications, then they're going to experience more constipation, right? NSAIDs and hypertension. So I think a while ago, I don't know, did anyone see in the news NSAIDs increase risk for a heart attack and sudden stroke and that kind of thing? No. So one of the things though, NSAIDs, especially in a lot of these patients with heart attacks, is hypertension. So this is kind of more acute or chronic NSAID use, so it's not like I have my toe hurts and I'm going to take some ibuprofen, but more like if you have arthritis and you're taking ibuprofen every day. So that's the kind of place where it's the difference. But it causes increased fluid retention, and so your blood pressure will increase if you're taking NSAIDs. Also, if patients have BPH, which we see in a lot of the patients, and they're taking like Benadryl or different antihistamines or different anticholinergics, they can have increased urinary retention, so they're going to have problems with their BPH. Compliance and adherence, so that's something else. So obviously when the patients take their medications, then they get the effects of their medications. And elderly patients, there's a couple of different issues with compliance. First of all, as you increase the number of medications that a patient takes, they're less likely to be compliant with their medications. So they've done studies and they show if you have one medication that you take once a day, you're going to be pretty compliant with that medication, right? But if you get to 4 or 5 medications and you're taking them 3 times a day, then compliance pretty much falls right out the door. Like there is no compliance with increasing complexity in medication regimens. Also, another problem with compliance in elderly is in order for a patient to take medication, they have to understand why they should be taking this medication, right? And so health literacy is kind of an important thing that when we're talking to patients, they have to understand the whole point of the medication. And so with elderly patients, that's kind of a barrier at times is health literacy and talking with elderly patients about the importance of their medication. And I found this to be kind of shocking in terms of most patients that are taking statins, 25 to 50% of them will discontinue their statin use within the first year of therapy. So patients are on a statin because they had a heart attack or because they had a stroke. Like, these are all lifelong indications of why they're on the statins. So it's kind of surprising to find out that half of them will discontinue it within the first year.
Can I ask you, what does BPH stand for?
Benign prostate hypertrophy. It was just a mouthful, and BPH was much easier to say, I think. Okay, so I feel like I made everyone really upset and sad, and I told you like there's lots of changes in the elderly, but we can't tell what's happening, and so like should we throw our hands up and go home, or so here is your ray of light, okay? Like enthusiasm ensues, I think. So what's great is in the past couple of years, and I'd say like in the past 2 or 3 decades, there's been some criteria that have been developed that really kind of help us when we're prescribing medications in elderly. And so, you know, this is really, so we'll talk about the Beers criteria and the start-stop criteria. So has anyone heard of either one of these, like the Beers criteria or start-stop? No? Okay. One thing that's kind of interesting and like close to home is so the senior ER, right, like therapy has a part in senior ER, and who else does? Social work. And then also pharmacy, right? So that's kind of like the triad that works on the senior ER. And so that's kind of pharmacy's part is when they get a referral from the senior ER, they look at the medications and see like, are they appropriate or inappropriate? And usually, and pretty much the key tools that they're using are the Beers criteria. So that's kind of a piece about, you know, like what work is being done with senior ER. So the Beers criteria was revolutionary when it happened. So it happened in 1991, and it was developed by a geriatrician. And he basically said drugs aren't the same in old people. And not only that, there's a lot of drugs that aren't safe in old people. And before that, it was like, you're a person, here's a drug. So this was kind of why this was different, right? So what the Beers criteria does, it looks for basically inappropriate medications. And it's medications whose risks outweigh the benefits, particularly in patients over 65. And it's not meant to be like a punitive system, like you gave this person Benadryl or something like that. It's just meant to be a tool for better prescribing. And kind of the key word they use throughout is potentially inappropriate medications, or PIM. So it was updated in 2012, so that was 1991, and then last 2012 we got some new information and some new criteria, which was good because some drugs aren't here anymore, right? So Darvocet was on the list as being a potentially inappropriate drug, and that got removed from the market. Was that like 3 years ago or something like that? So, you know, it's good that there's some updating. So the first category is medications that pose a high risk of adverse effects or appear to have limited effectiveness in older people. And there's alternatives. The second category is drugs for patients who have certain diseases, and those drugs should be avoided in those certain diseases. So that's 50 medications. The third category is drugs to use with caution. So you might have reasons to use these medications, but be careful if you are. So let's just talk about a couple of the medications on the list. Are we good with time?
You got 15 minutes.
All right, we'll figure it out. So these are drugs to avoid in patients. So nitrofurantoin, is anyone familiar with nitrofurantoin, like why you would use that drug? No. So if you have a bladder, or if you have a UTI and you go to the doctor, you're pretty much going to get nitrofurantoin. It's like first line drug for UTI. It's really cheap, it's been around for a long time, it works really well. Except in old people. It doesn't work very well in old people. And so Mr. Beers, he recommended that we not use this drug in elderly patients over 65. And the reasons are really good. So first of all is the drug's not eliminated. So we talked about creatinine clearance and how that helps in knowing if a drug's eliminated from the body. And they're telling us if your creatinine clearance is less than 60, it's not going to be eliminated from the body. Okay, so that's a good reason to avoid it because you're going to get CNS side effects, you're going to get pulmonary toxicity, so I wouldn't want that, right? Also, another thing to think about with nitrofurantoin is if you have a UTI, where do you want the drug to get? You want it to get to the bladder, right? So the way that we get drug to the bladder is when it's taken up through glomerular filtration, which is telling us in these patients is not effective. So the drug that you're giving to treat their UTI isn't actually getting to the site of action. So, you know, it's kind of like, it's a well thought out list, right? Like he's giving us good reasons. Yeah?
What's the common name for that drug?
Macrobid, macrodantin. Is that better? Yeah. Okay. So also drugs to avoid antipsychotics or conventional or atypical. And that's because they're showing this increased cardiovascular accidents and also cardiovascular mortality, and particularly in patients with dementia. And this is kind of interesting. CMS, maybe 15 years ago, came into nursing homes and really did a lot of work about reducing atypical antipsychotics use. You know, maybe 15 years ago, if there was an elderly patient with dementia that had some sort of behavioral disturbance, they got Haldol, and they were like, here's your Haldol, and you know, they gave a lot of Haldol. And within the last 15 years, the CMS has really done a lot of steps that looking at, is this appropriate, do you need to discontinue use, and after 6 months, I think it needs to be reviewed, and either the dose needs to be reduced or it needs to be discontinued. So, you know, that's because of increasing risk and mortality in these patients. So it's not saying avoid it, right, but it's saying use it to the lowest dose and avoid it if possible. Also, glyburide, insulin sliding scale, they're saying that a patient's more likely to have hypoglycemia. So we know now hypoglycemia, if you experience hypoglycemia, then you increase your mortality, right? So these are some older diabetic medications that aren't eliminated in these patients, so they're getting increase in hypoglycemia. This is kind of at home, don't use insulin sliding scale. Also benzodiazepines. Reglan is kind of an interesting drug. So in elderly patients, if I've seen this before, if you give someone Reglan, they can experience severe movement disorders. So extrapyramidal symptoms and tardive dyskinesia. And so it's saying, you know, basically in these patients, unless they have gastroparesis, which is a very good reason to give Reglan, you should be giving some other agent. So thinking about, you know, giving them Zofran instead, right? So Reglan really shouldn't be a first-line drug for nausea. And then also NSAIDs, so there's a risk of GI bleeding, and if you have to use it, use with a proton pump inhibitor. Let's see. So we have some drugs and diseases. So again, if you have syncope, avoid drugs that cause orthostatic hypotension. If you have insomnia, avoid drugs that are CNS stimulants, right? Like oral decongestants, and for example, Sudafed is a good drug that is a stimulant essentially. So if you have patients that are elderly and experiencing a lot of insomnia, probably pseudoephedrine is not the best drug for those patients. These are kind of interesting. So these are drugs to use with caution. And Pradaxa or dabigatran is one of the new oral anticoagulants. Have you guys seen this drug at all? No. So this drug is like the first to market with the new oral anticoagulant. So now you have Xarelto, right, and Apixaban. These are other new drugs in this class, but Pradaxa was one of the first drugs in the market, and they really marketed for older people with atrial fibrillation. So that was kind of like their niche, right? And after a couple months of this drug being on the market, there were lawsuits and there were ER visits where patients were experiencing an increased amount of bleeding and like intracranial hemorrhages, so really severe side effects. So these patients, they're more sensitive to the side effects of the newer anticoagulants, where with warfarin you can say, oh, here's a drug, here's your INR, right? With the newer anticoagulants, it's not as hard to say, so they're experiencing increased sensitivity. So that's really a drug used with caution. And really the popularity of Pradaxa or dabigatran has sort of fallen off the market. So I'm thinking in a couple of years it'll be moved over a category to the do not use. So the Beers criteria is sort of awesome because I told you it's revolutionary and it's really cool and it gives us a way to think about it. It's not all-inclusive. Sometimes it doesn't give you alternatives, so that's kind of a problem. It says don't give this, but it doesn't say like, but use this instead. So it's not, there are some shortcomings to the list. Also, it doesn't talk about drugs that are a problem for everyone. So we're saying these are drugs that are a problem for elderly patients, but it's important to remember that some drugs are a problem, cause problems for everyone, right? So it's not like an all-inclusive list. But this list has been around since 1991, which is a long time. So I think it's interesting to look at how common it is in long-term care. So this was a study done about 4 years ago, and they looked at drugs prescribed in long-term care and how many patients were taking that were on the Beers criteria. So you can see 93% of patients had one drug that was on the Beers criteria, 18% had 2 drugs, and 2% had 3 drugs. So it's really interesting that this list has been around for that long, but these medications are still being used quite a bit. Okay, so another tool that's different in prescribing for elderly is the stop criteria and the start criteria. So stop criteria are drugs to avoid, right? And then there's the start criteria, which are drugs that you need that you should be on, which is kind of neat, like they use them in conjunction with each other, like stop taking this, start taking this. It might be a little bit more useful than the Beers criteria in identifying meds that have negative outcomes, such as hospitalization. So there have not been very good links of the Beers criteria to like you will end up in the hospital, but the stop-start criteria has been validated in that setting, so it might be kind of more useful. So just going through a couple examples here. So this is the stop criteria. So medications that you're taking that maybe you shouldn't be on. So loop diuretic is first-line therapy for hypertension. So we just talked before, like elderly patients are more sensitive to loop diuretics. They're going to be more likely to have electrolyte imbalances or dehydration. So if you're treating hypertension, loop diuretics like Lasix or Demodex probably aren't the best first-line agent. Another example is aspirin in doses greater than 150 milligrams. So enough studies have been done about aspirin that's saying in elderly patients, patients over 65, there's no benefit of taking aspirin doses greater than 150 milligrams. And you're increasing your risk pretty profoundly. So that's like an 85-year-old that's taking aspirin through 25 twice a day. That's probably an unwarranted risk in that patient. Other medications to stop are NSAIDs, and this is kind of NSAIDs and chronic use, right? So it's not like you're in the hospital, here's some NSAIDs, but you're taking an NSAID every day at home, and this is meds that really should be avoided. And again, any duplicate drug is another good example. So if you're taking 2 NSAIDs at a time, which sounds ridiculous to some people, but a lot of patients are taking 2 meds at a time, and we see this coming in on their home history, like they're taking Celebrex and ibuprofen, or they're taking 2 of these NSAIDs together. So again, they're just increasing the risk for side effects. Also benzodiazepines, if you're taking a benzo for sleep and then a benzo for anxiety during the day, and they're different benzos, then again, you have different onsets, different durations, so you're going to be more likely to have side effects from it. START criteria is meds that you're not on that you should be on. And a lot of these are coming from evidence-based guidelines, and I think kind of it's nice because there's like 15 of them, and it's a quick thing that you can look at their profile and be like, why aren't they on this? So it's a nice succinct list. So an example would be a beta-2 agonist or an anticholinergic agent for asthma or COPD. So a lot of times if people are taking their albuterol all day long, that's kind of a good place that they can make an intervention with. Levodopa in patients with Parkinson's disease is another example. Proton pump inhibitor in a patient with GERD. I don't know, that one's a little controversial in my mind, but I think that proton pump inhibitors are a little overprescribed. If a patient has atrial fibrillation and they don't have a contraindication, they should be on warfarin. And if they have a contraindication to warfarin, they should be on aspirin. Doses less than 150, which we just talked about. But, so it's kind of a helpful list looking at things. So just to kind of summarize. So these are interesting, they're kind of, I'll just leave it here. They're kind of new tools that we have in terms of looking at patients in the last 20, 30 years. And they're helpful for pharmacists, for physicians, and I'm hoping that they're helpful for you guys when you're looking at your patients too, to think about, the bigger picture of why they experience these side effects, or maybe they shouldn't be on this drug, just to kind of start a conversation. So next, I just wanted to talk briefly about medications and falls. So we talked about changes in kinetics and changes in dynamics and all these changes in patients and side effects. And the one thing that I think is becoming one of the biggest side effects that we're seeing, particularly in elderly patients, are falls. So we don't know exactly how many falls are related to medications. That's completely not known because falls are not considered a side effect, and so they're not reported as a side effect. So it makes it really difficult to know. But in study after study, falls or medications have been identified as one of the risk factors for falls. I think that this is really interesting. About 1/3 of people that live in a community dwelling over 65 have at least one fall a year, and 1 in 8 have 2 falls a year. And they say as patients approach 80 and older, it's actually 50% of patients will fall once a year. So that's a lot of falls that we're experiencing. And just looking at, what are the implications? So $28 billion is spent in healthcare on falls, which I think they said is like 2% of our GDP or something, which is insane. Isn't that insane? So looking at falls, these are some, people know that falls are a problem, and so there have been a lot of studies that have looked at what's causing falls and figuring out ways that we can avoid falls. And so a lot of these are things you can't change, like you can't change your age, but some of these are modifiable, like drug use. And the things that most studies have come away with is most falls can't be attributed to one cause. It's usually multifactorial. In terms of types of medications that cause falls, so this is from a meta-analysis, and it looks at the odds ratio. So how likely are you to have a fall versus if you're on the medication versus if you're not on the medication. So I thought some of these were interesting. They came up in this list, and then some of them are kind of predictable, like narcotics and falls seems pretty predictable to me. If you look at the confidence interval, when we're looking at studies, if the confidence interval includes 1, that's not statistically significant, versus if it does not include 1, then it is. So if you look at antidepressants, that's a statistically significant number that we're saying, like, if you're on antidepressant, you're going to be more likely to fall. Versus beta blockers is not statistically significant, so that could be more because of confounding sort of information. Antidepressants, it's interesting. Obviously, they're causing falls primarily because of orthostatic hypotension and dizziness. And it's not so much with chronic therapy. So studies have looked at if you're on a new antihypertensive or if you're on an antihypertensive, when is it likely to contribute to a fall? And this is primarily during the first 14 days of therapy. So I just think that's kind of interesting information knowing. So if someone's been on amlodipine for 5 years, it's probably not the cause of the fall versus them starting hydrochlorothiazide last week, like that would be a good medication to look at. And to make interventions too about how to stand up slowly, right? Or how to change your position. So it's kind of interesting information. Antidepressants and falls. So data in meta-analysis has shown that all elderly who begin therapy with an antidepressant are at increased risk of falls. And those on antidepressants are 300% more likely. So that's huge, right? So we looked at the Beers criteria and the start-stop criteria, and tricyclic antidepressants are on all of those lists as medications that are probably not safe in the elderly. It's interesting though because the risk is about the same with tricyclic antidepressants and newer antidepressants. So If you're giving someone Paxil, you would think like they would have less of a risk for a fall, but that's not really the case. It's about the same. And again, it's usually, they say, because of sleep disturbances, that's most likely causing the falls if someone's on an antidepressant. Like the SSRIs are more likely to make someone awake, right, and have a hard time sleeping, which can cause falls. And then the tricyclics are more likely to cause someone to be drowsy, and again, more likely to cause falls. So it's kind of opposite reasons. It's interesting too that the risk of falling is about the same with a person starting on an antidepressant as someone that has untreated depression. So we've seen from other studies that depression is the cause of falls, and your risk is about the same if you're an antidepressant. NSAIDs and falls, I thought that was kind of interesting. So it's usually with chronic use of NSAIDs is where they're saying that this is likely to happen. And we see NSAIDs on the Beers criteria and the start-stop criteria. So again, thinking about how appropriate this is in elderly patients. I think the confounding thing about thinking about NSAIDs and falls is unmanaged pain and chronic pain are also risk factors in falls. So, I don't think it's as cut and dry as like I'm giving them Feldine and they're going to fall, versus there's a kind of a group of things going on. And benzodiazepines and falls, and this drug, we've seen them in every single list and patients, and basically it's saying that benzodiazepines aren't usually the best drug in elderly patients. Like it has its place for detoxification and that sort of thing, but for chronic use in elderly patients, benzodiazepines have quite significant risk. There's 10 to 12% of patients that live in community dwellings are using benzodiazepines, and if it's usually used for sleep, the effect of benzodiazepine for helping you in sleep lasts about 2 weeks, and then that falls off because you develop tolerance. So you don't see a lot of efficacy and help with a person sleeping for a long term. But I think 80% of elderly patients that are prescribed benzodiazepines are continued for up to 2 years. So we see a lot of long-term use in elderly patients. Again, like I said, it does have its niche. Like it's important for seizures. It's important if you need a muscle relaxant on a short-term basis. It's important. So there are places that it does have a place. It's just, it is a very high-risk medication when it comes to falls. All right, so just to conclude in a timely manner, so elderly patients are a growing population. So these are not simple patient population, right? We've seen a lot of changes. They're more likely to have side effects. But I'm sorry.
What age do you consider elderly?
So that was a little controversial earlier because I quoted a study that defined elderly as a little younger. So usually the studies are saying 65 and older is where you can define that within the elderly criteria. So now they're trying to separate that group between like young elderly and elderly or something like that. But most of the studies are studying 65 and older as elderly. So this is a growing population. People are living longer. There's significant challenges when managing medications. There are some tools, so it's not, gloom and doom. Like there are some nice tools like the Beers criteria and the stop-start criteria to help us use more appropriate medications in these patients. And I think really kind of, I was bringing this information here to give you kind of a more well-rounded view of the patient, because in terms of healthcare, it's really moving towards team care of a patient, right? And so kind of by understanding all different parts of the patient and the team, I think we can give better patient care. That's it.
Yeah, so who's responsible when all these patients are on multiple medications and you have these great tools, the Beers and the start-stop, but who's looking at the whole picture of a patient's list of medications and looking how they all work together? Who's doing that for one person? Which doctor, or is there anyone really looking at it?
Well, I think kind of that's where we're going, I think, maybe in healthcare, maybe I'm wrong. But, there's a lot more studies looking at a team approach and patient care as a part of a team. So, by doing stuff like that, you get a better picture of the patient and a whole view.
And I'm just wondering if there's one doctor that's responsible for that, because we see so many specialists there.
Yeah, so, in general, I don't know.
I mean, it really should be the primary care physician who's
Yeah.
managing their whole realm. But you're right, think about a specialist. The specialist only wants to be responsible for the meds they're prescribing, the pain meds or the NSAIDs or whatever. But yet the primary care still needs to know that. And I think that's, having a senior ER and having a pharmacist actually going through their whole list of medications to see, that's a start. That's one place we're starting. And the second step is on the inpatient side and looking at all the meds. You know, and again, we're relying on the patient right now and the family to give us a list that's accurate.
Yeah.
And that's another problem that we have too, right? And the other thing that also complicates that as well is even pharmacists, I know my parents do not use just one pharmacy. They get this drug at this pharmacy, this one's through the mail, and this one they get at Kroger's because it's cheaper at Kroger's for whatever reason. So they might use 3 different pharmacies. Well, if they're not providing that full list to that pharmacist, because I think that happens as well in outpatient pharmacies, is that they will look at all of your meds and they would say those recommendations, you know, using beers or whatever as well. But if they don't have that full list, they don't know either. So, yeah.
That's a good question.
I had another question. I wanted to ask you about Lu-Moran. That's a medication that we see a lot of patients using. And I just wonder, what's the classification of Lu-Moran? What kind of a medication is it? And also, the side effects I think are dizziness when you first start. I seem to see, I don't know what you feel like, we see patients who've been on it for years, for a long period of time. Is that the kind of thing where the dizziness could come back at any time, or?
So usually not. So Neurontin is kind of probably being used in a lot of patients. Originally started as like a seizure med, but now it's kind of being used more for pain, especially like neuropathic pain. And so exactly what you said. So when you're starting Neurontin, the side effects are dizziness are usually the most common side effect, which does stop after a while. So that's something that eventually will like you usually don't see dizziness later unless maybe like if someone there was a change in their renal function or something, then potentially if they're like accumulating more of the drug, that could be potentially coming back. But usually dizziness subsides after a while. That was the word I was trying to think of. Subsides.
Right.
Okay.
Thank you, Rachel.